So first of all, thank you very much to Dr. Finkelstein for the opportunity to talk about adjuvant radiation for bladder cancer, the who, what, and how. Here are my disclosures. And this presentation is really the background and discussion session for an ongoing NRG trial, GU001. I'm going to answer actually the bottom three questions briefly, and I'm going to discuss the rationale for adjuvant radiation, in particular describe who we think is most likely to benefit from adjuvant radiation, what are the subregions in the pelvis that should be targeted in this population, and how those patients should be treated. So I'm going to briefly summarize the entire presentation. I'm going to not necessarily touch on all these points, but over the next 15 minutes or so, I'm going to tell you that neoadjuvant radiation may be a more rational approach, but is challenged by difficulties in selecting patients who are most likely to benefit from adjunctive local regional therapies. I'm going to tell you that adjuvant radiation has a compelling rationale and should be reevaluated in the modern era. Then I'm going to describe to you patients who I think are most likely to benefit based on risk factor analyses, and they have extravesicular disease, positive margins, and/or less than 10 lymph nodes identified in the pathology specimen. I'm going to tell you about the approach to treating these patients that we're taking it with the NRG, and both from a targeting CTV point of view and from a technical point of view. So just to level set, patients with muscle-invasive bladder cancer do poorly, and they've done poorly for a very long time without much improvement. Patients with extravesicular disease at the time of surgery have a 5-year overall survival of about 40%, and that's not changed. We've done studies where we look to see if it's improved over time as a result of improving surgical techniques, and it's not. The one thing that has changed it is chemotherapy, but that was established 2 decades ago. So I'm just going to skip over these slides just out of respect for the time, and just highlight one thing. When we stage bladder cancer patients preoperatively, we do a very poor job. If you look at clinical T2 patients who are staged clinically T2, they are about as likely to be PT2, pathologic T2, as they are to be PT3 and something less than PT2 or even PT4 disease. So this is the main reason why we are taking an adjuvant approach, because we can't actually adequately stage right now patients preoperatively. So the hypothesis that underlies the adjuvant radiation paradigm is that if we improve pelvic control, we will ultimately improve survival. There's retrospective data to suggest that that's the case in bladder cancer. There are certainly some diseases where you wouldn't expect that to be true, but in bladder cancer, we see that local failure often precedes distant metastases, but not the other way around, suggesting again that a lot of these patients are failing first in the pelvis that leads to distant metastases. In addition, there is a retrospective observation that more aggressive surgery is associated with improved survival. So intensifying the local treatment is associated with improved survival in a retrospective manner that's currently being evaluated in a prospective trial. But again, this gives us some motivation to intensify treatment to the pelvis. There's even, excuse me, there's even prospective data out of Egypt that, again, supports the hypothesis. There was a trial published in 1992 that was a randomized trial, 3-arm study that looked at 2 adjuvant radiation paradigms, a BID and a QD approach versus cystectomy alone. And the outcomes were significantly, the disease-free survival was significantly improved in the adjuvant radiation arms. Now, the big caveat here is that these patients were diagnosed and treated in Egypt, and they were primarily squamous cell carcinoma, so not what we see in the Western paradigm. Despite the fact that there's compelling rationale, and this 1992 paper, adjuvant radiation did not catch on in the 1980s and the 1990s, in large part because there were reports that raised concern about undue toxicity. particularly with respect to small bowel obstruction. So I'm just going to tell you that I think that the studies that were done that raised these concerns were limited for several important reasons. First, when they calculated the toxicity burdens of adjuvant radiation, they didn't compare them to the cystectomy alone patients. And it turns out, as we are learning more and more about the complications of cystectomy patients have lots of complications. And in fact, if you follow cystectomy alone patients for a year, about 35% will have some sort of bowel toxicity. If you follow them for 5 years, 75% will have a bowel complication. And so if you just look at patients who got cystectomy and radiation, you're apt to attribute toxicity to radiation, which may actually just be related to the surgery itself. That's not to say that radiation isn't going to increase toxicity. It certainly will, but probably not to the extent that was initially reported on in the 1980s. In addition, the techniques that were used in the 1980s, APPA, big fields, we can do better than that. So there's reason to think that we really should reevaluate the role of adjuvant radiation, particularly in this cohort of patient, again, who hasn't seen improvements in 2 decades. All right, so I'm going to talk now about which patients are most likely to benefit, which patients should be included. So my group at Penn, as well as other groups, have been thinking a lot about which patients are most likely to benefit through these studies that are what we call risk factor analyses. So unlike in the neoadjuvant setting where you don't have a lot of clinical information, in the adjuvant setting, you've got the cystectomy specimen. You've got a ton of good information about the aggressiveness of the tumor and where it's likely to recur. So we and others have done risk factor analyses and explored all of the data that's coming out of the radical cystectomy to try to identify factors that predict benefit for adjuvant radiation. And as we go through it, there are 3 factors that really stand out when you do a competing risks analysis. And the first factor is that the patient has extravesicular extension, PT3 or PT4 disease. That's the most important factor. Then it seems like the aggressiveness of the pelvic lymph node dissection also affects the likelihood of pelvic failure. And then finally, whether or not they have positive soft tissue surgical margins, which obviously makes sense. There are factors that I think would be intuitive but don't necessarily play out. The first factor is positive nodes. Positive nodes likely predicts pelvic failure, but those patients also have very high competing risks for distant metastases. And so pelvic nodes may not predict who benefits from adjuvant radiation. Chemotherapy has been looked at left, right, front and center, and it doesn't seem to modulate the risk of pelvic recurrence. So this is a risk stratification that we've proposed at Penn and developed in 2 separate databases, and it's got 3 groups. The low-risk group is patients who don't have any extravesicular disease. Their local failure rate is about 8%. There's the intermediate risk group who have extravesicular disease but have negative margins and a thorough lymph node dissection. They have a pelvic failure rate of about 20% at 5 years. And then there's the high-risk group with extravesicular extension, positive margins, or less than 10 lymph nodes dissected, and they have a pelvic failure rate, a cumulative incidence of 41%. And this risk stratification has been externally validated in 2 very different databases. One is a European cohort of patients, all of whom had surgery in 2011, so a modern cohort of radical cystectomy patients. The risk stratification works in that cohort. It's been looked at in an Asian population, in a Korean population, a historical database, and it works in that database. So this risk stratification is robust to temporal variations, regional variations, and patterns of surgical care, patterns of pathology care. In addition, the risk stratification stratifies patients according to overall survivals, and that lends credence to the fact that it's saying something clinically relevant. And interestingly, it doesn't seem to stratify patients with respect to distant metastases, which I interpret as meaning that the stratification isn't simply a prognostic tool. It's not simply identifying more or less aggressive tumors. It is doing what it's supposed to do, which is modeling risk of pelvic recurrence. So something which is highly correlated with aggressiveness, surely, but not directly correlated. So we can use this tool as a selection tool for clinical trials. So can we identify patients most likely to benefit from adjuvant radiation? I think the answer is yes. And what are the subregions of the pelvis that we should target? In order to inform this question, we did a patterns of failure study where we a priori actually identified 7 regions of the pelvis, and we actually added an 8th because it was clear that some of these failures were did not easily fall into one of these categories. But we identified these subregions of the pelvis, and then we went through our institutional cystectomy series and mapped where the failures occurred, where the centroid of the lesions were within these subregions. And we made 2 observations that I think are relevant. One is that, again, patients with extravesicular disease at the time of radical cystectomy have higher rates of pelvic failure in all the subregions of the pelvis. And then the other observation was that patients with positive surgical margins seem to have a different pattern of failure. In particular, they failed in the center, the central pelvis more often in what we call the cystectomy bed. So if you look here, you see that the cumulative incidence of involvement of the cystectomy bed in patients with positive margins was approximately 13% versus only 2% in negative margins. And that raises the possibility of sparing the central pelvis in patients with negative margins. And maybe that helps us shift the therapeutic ratio for adjuvant radiation in those patients. So we're able to take that patterns of failure data and model hypothetically how different clinical target volumes would cover failures in our cohort. So for example, if you look at sort of the top row here, iliac obturator and pelvic sidewall, that's really the pelvic sidewall. That's a hypothetical pelvic sidewall CTV. And then we ask, if we were to treat patients with PT3 plus disease, what percentage of the patients with negative margins would have had all of their lesions, the centroids of their lesions, covered by this hypothetical CTV? What percentage of positive margins patients would have their centroid of their lesions covered by this hypothetical CTV? And you can see here that for positive margin patients, just treating the pelvic sidewall is probably clearly inadequate. But it actually does reasonably well for negative margin patients. And if you expand your CTV, you can get adequate coverage in positive margin patients. If you treat comprehensively, you can cover 91% of the recurrences that we saw. But you also improve the coverage for negative margin patients, but not at the same rate. So it may provide some rationale for sparing the center of the pelvis for negative margin patients. But again, this is a judgment call. And in order to make this decision, we sort of organized an international collaborative discussion of interested parties that included 18 radiation oncologists, 7 urologists across 15 institutions in Canada, the UK, US, France, and India. Dr. Finkelstein and Dr. Efstathiou kindly contributed to that effort. And we just talked about, well, what is the right, given the available data, what should we treat in negative margin patients? What should we treat in positive margin patients? And we have a paper coming out that has a bunch of recommendations on how to treat these patients. But 2 points just to make here is that we did think that treating negative margin patients with just pelvic sidewalls would be appropriate. But for positive margin patients, we wanted to treat more comprehensively, and you can sort of see the DRRs here, treating the pelvic sidewalls in negative margin patients, but including the cystectomy bed, where, frankly, a lot of the small bowel you might expect to fall in after a radical cystectomy. The other thing that I think is important, what we did in that sort of international collaborative discussion was come up with language that defines what the cystectomy bed is. Most of us haven't contoured a cystectomy bed, certainly not in the last 20 years. And so what is the cystectomy bed in a woman? What is the cystectomy bed in a man? And we came up with language and iterated that language that hopefully produces a consistent contour in the United States and the same contour in India, where these clinical trials are going to be running. And so that will hopefully be coming out in the very near future. This language has already been incorporated into the NRG study. It's being incorporated into trials in the UK, France, and India as well. So how should patients be treated? Well, it won't come as a surprise to this audience here that modern radiation techniques do a better job at sparing the rectum and the bowel post-cystectomy. And we really did this paper to shore up discussions with our insurance provider, who may question the role of IMRT or even proton therapy in these patients. But we did a dosimetry study basically showing that, yes, if you use modern techniques, you spare bowel and rectum better. And we also showed that sparing the cystectomy bed has meaningful decrements in dose to the rectum. So who should be treated? In my view, patients who should be included in these trials are intermediate and high-risk patients according to that risk stratification. How should they be treated? I feel a little less strongly about this. In fact, the clinical trials are going to go in different directions, so we can do a meta-analysis afterwards. But the NRG trial calls for pelvic sidewall only radiation for negative margin patients and more comprehensive radiation for positive margin patients. And in the NRG trial, because of the broad availability, we're requiring IMRT. And I'm just going to leave you with 2 slides here showing data that was presented at the GU Symposium a couple months ago. This is from a prospective cohort study, again out of Egypt, but in my mind it's a little more interesting this time around because 50% of the patients were urothelial carcinoma. And they followed prospectively cohorts of patients who were treated adjuvantly with radiation and chemotherapy in a sequential manner versus patients who only got adjuvant chemotherapy. And you can see the local recurrence-free survival is nearly perfect in the patients who got adjuvant radiation and not perfect in the group that only got chemotherapy alone. The disease-free survival doesn't reach statistical significance, but is intriguing, a 12% absolute advantage for the adjuvant radiation and chemotherapy arm versus chemotherapy alone arm. Overall survival similarly doesn't reach statistical significance. It's a tiny study, but there was a 13% absolute difference in 3 years for the arm that got radiation. So I'll leave you with that. If you're interested in the trial, participating in the trial, please talk to me or Jason Efstathiou afterwards.
So bladder-sparing therapy, we know that organ conservation is commonplace in contemporary oncology, and in muscle-invasive bladder cancer, radical cystectomy is standard. We all know that. There are no completed trials comparing surgery to chemoradiation. What we do also know is that the median age of muscle-invasive bladder cancer patients is about 73 in the US right now, so this is an elderly population. And if you look at rates of cystectomy by age group, what you notice is that once you get to the age of 70 and above, cystectomy is being used in less than 50% of men. In fact, if you define aggressive therapy in bladder cancer as either a cystectomy with or without chemo, or chemoradiation or radiation to definitive doses, look at this. If you're over the age of 80, 60% of patients with muscle-invasive bladder cancer, which is obviously a disease with high mortality even in a few years after diagnosis, over 60% are not receiving any aggressive therapy in the United States. So these are large practice pattern studies. So what is the modern alternative to cystectomy? It's a maximal, ideally visibly complete TURBT. It's key to engage your urologist in this. Often patients need more than one TUR. We routinely will do 2. Contemporary conformal radiation and radiosensitizing chemotherapy. Here's the general paradigm that's been used within the RTOG, NRG, and at our institution, which does a maximal TUR, an induction course of chemoradiation to 40 gray or so, a cystoscopic response evaluation. If the patient's a complete responder on rebiopsy at that interval assessment, then they go on to complete consolidation chemoradiation to a total dose of mid-60 gray, and then frequent surveillance cystoscopies with recurrences in the future leading to a prompt salvage cystectomy. Similarly, if patients are non-complete responders after induction chemoradiation, and they continue to have persistent muscle-invasive disease, salvage cystectomy is recommended at that early time too. You don't have to do it in a split course way. This slide just shows that. Going single course through, I mean, the RTOG has had complicated schemas of BID radiation and this sort of split course treatment, but doing single course Q-day radiation to full dose, mid-60 gray range, is perfectly fine as well, and then doing cystoscopic evaluations thereafter, reserving salvage cystectomy for recurrences. So the approach to bladder preservation has evolved over the years. We used to use neoadjuvant chemo, we don't anymore. We introduced accelerated radiation in the mid-90s, and we've been tinkering with enhanced radiosensitization in the last couple of decades. So I'm going to present two studies that have been presented at ASTRO and GU ASCO but are unpublished, so to try and give you a flavor of updated results on bladder-preserving therapy. So this is our institutional experience, 475 patients with muscle-invasive disease, and we're looking at survival endpoints. Here's the cohort of 475 patients. What you'll note is 3/4 are male. That's standard in bladder cancer. 2/3 had clinical T2 disease. Remember, when we're doing bladder-sparing therapy, we do not have the benefit of pathologic staging, and there is big stage discordance. But clinically, 2/3 were T2. 1/3 of patients were higher grade. And by the way, 1/4 had carcinoma in situ, though in general, this was not extensive multifocal CIS. This was sort of tumor-associated CIS. 1/4 of patients received neoadjuvant chemo. Those are the older patients, meaning in the earlier years in our experience. Credit to our urologists, 70% had visibly complete TURs. And overall, 75% achieved a complete response to induction chemoradiation. So very, very good results there. So we have good long follow-up in surviving patients. It's over 7 years. And again, 75% achieved a CR over the entire experience, which again dates back to the mid-80s. Here, look at the actuarial rates of failure. Non-invasive failure rates, invasive, pelvic, and distant failure rates. What you'll see is there isn't a big difference between 5 and 10 years. So similar to cystectomy, if you get to 5 years, there aren't a heck of a lot of events later. What can still happen are non-invasive recurrences, which we've shown can be managed as we would anyhow, conservatively, with TUR, perhaps intravesical PCG. And we do recommend that patients have lifelong cystoscopic surveillance, not just to 10 years, because some of those non-invasive recurrences can happen after 10 years. I just want to show you, these are the changes in complete response rates over time. So I said 75% for the whole cohort, but in fact, we're approaching 90% in more recent treatment eras, 90%. Why is that? Well, we've selected our patients better. There's no doubt about that. Generally are reserving this for T2 disease, no hydro, and patients ideally have had a visibly complete TUR. Indeed, I think the radiation's gotten better, and I think the concurrent radiosensitizing chemotherapy has also gotten better over the years. So we're approaching 85 to 90% CR rates these days. These are our overall survival disease-specific curves, again, for the entire cohort. Look at the one on the right, the disease-specific survival, and compare it to this, which is a very large long-term cystectomy cohort, combined cohort. They're very, very similar. Very, very similar in the longer term. So let's just quickly look at factors associated with survival. So overall survival, we'll just look at multivariate analyses. Obviously, age is associated with overall survival, but T stage is really important, and whether or not you had a CR, and hydro actually was important for overall survival too. If we look at disease-specific survival, the two factors that remain significant in multivariate analyses are the T stage and whether or not you achieved a complete response. It's great because a complete response is a very early marker and therefore can be a surrogate marker for these patients. Here are our results split up by whether you were T2, which is in red on the top, or a T3, T4. Look at the top right-hand panel. If you're a T3, T4, so more advanced stage disease, clinically advanced stage disease, still 50% disease-specific survival rates in the longer term. That's pretty darn good. We've developed nomograms for this. Long story short, if you're a clinical T2, you've had a complete TURBT, you have no hydro, your complete response probability is at least 80%, probably higher these days, and your 5-year disease-specific survival probability also approaches 80%. This definitely rivals cystectomy series. Neoadjuvant chemo, and again, I apologize, I'm going faster, but I just want to get through as much as we can. Neoadjuvant chemo was not associated with survival endpoints in our experience. However, there are some caveats to this. These are the older era patients. There was only 2 cycles of MVAC chemotherapy. Most medical oncologists would prescribe 3 cycles. And there were some chemotherapy-related grade 5 events, which in this modern era of better supportive care, we think would be much, much lower. So it's probably still a question out there, and if you're working with your medical oncologists who like to give neoadjuvant chemo, it's totally fine. You can still do chemoradiation. In fact, maybe it's even better and should still be studied in the more modern era now. This treatment works as good in young and old, split by age 75. So remember the undertreated population on the first few slides. This is a great alternative. So when you're working with your urologists, those that they're hesitant to do a cystectomy in, here is a wonderful alternative for those older patients. So overall, 27% of the patients in our series required a salvage cystectomy. I'm going to just jump to the bottom point there, though. In the more modern treatment era, meaning since 2005, that number is down to 15%. So our current rates of needing a salvage cystectomy, either for a non-complete responder or for an invasive recurrence later on in follow-up, is 15%. So how do we compare to cystectomy? Well, if you look at modern cystectomy series on the top and modern chemoradiation series on the bottom, 5 and 10-year overall survival, they look pretty similar. And remember, there is a T-stage discrepancy, big clinical pathologic stage discordance. If you are if you are thought to be a clinical T2, 46% of the time, you would actually be upstaged at time of cystectomy. So remember, when we're saying our best patients are those T2, actually, almost half of them are actually probably T3. So we're doing pretty well here. So long story short, we have outcomes that rival modern radical cystectomy series. At least 75% of patients are achieving a complete response, approaching 90% in the more modern era. And we really do believe that trimodality therapy is an acceptable alternative to radical cystectomy in selected patients. So, which chemotherapy with radiation? Here are all the active radiosensitizing drugs. I'll tell you what we use. We use doublets, cis-5-FU, or in patients who are not cisplatin candidates for renal function or otherwise, mitomycin 5-FU, which comes from a UK trial. But there are other good agents that are listed there. Long story short, over the years, by tinkering with these radiosensitizing chemotherapy regimens, response rates have gotten better in our experience and also in the German experience. This is a randomized phase 3 trial that you should all know, that I'm sure appears on all kinds of different kinds of boards that would draw from this trial. It was a trial from the UK of radiation plus minus chemotherapy. The chemotherapy was 5-FU mitomycin C. Again, you can use that in patients who have lower GFRs. This is how the chemotherapy was given. I'll skip that. But their primary endpoint was 2-year local regional disease-free survival, and the addition of chemotherapy to radiation improved that significantly. At 2 years, there was no difference in overall survival, though with longer follow-up, those curves appear to separate when we await those results. But this basically proved that chemoradiation is better than radiation alone. In the RTOG, this is the most recently reported trial, 0233, which looked at BID radiation and cis-5-FU versus cis-Taxol. Long story short, either of those are fine. Cis-5-FU or cis-Taxol, equally good survival, equally good bladder intact survival, as shown in these curves. This is the last RTOG trial, which closed in 2014, has not yet been published. It was BID radiation and cis-5-FU, so it took one of the arms from that last trial, compared it to a regimen that was developed at Michigan and in the UK of Q-day radiation and gemcitabine, very low dose gemcitabine, 27 milligrams per meter squared given twice a week. Just a whiff of gemcitabine, it's a very potent radiosensitizer. So we'll see what those results look like when they're reported. So we still have 4 minutes here. So let's touch on quality of life after chemoradiation. How often does cystitis happen? How often do contracted bladders happen? What is the quality of life after this treatment? We pooled a lot of RTOG trials and showed that there's about a 7% grade 3 toxicity rate, about 6% GU, 2% GI. That's pretty acceptable. There was no grade 4 or 5 in the RTOG experiences. Anthony Zeitman did an MGH study, quality of life study, and did urodynamics in those patients, showing that about 80% had compliant bladders, normal capacity. 85% had really no urgency or only occasional urinary urgency. A quarter of patients had some moderate bowel control symptoms, and 50% retained erectile function. That is way better than cystectomy series. Cystectomy series, if you're in the 10 to 15% range, you're lucky. So there's a big win as far as sexual function for chemoradiation. The Germans asked in the Erlangen experience, asked if you were to spend the rest of your life with your urinary condition as it is now after chemoradiation, how do you feel about it? 90% were either mostly satisfied, pleased, or delighted. So quality of life seems to be good. So what we did is we actually did, the point is that health-related quality of life is not well studied in survivors of bladder cancer. Mostly single institution, non-validated questionnaires, and really no comparative data, good comparative data is out there. So what we did is we partnered with UNC and did a quality of life study in long-term survivors after either chemoradiation or cystectomy. We looked at all relevant domains. Again, it was a couple of institutions. The patients had to be disease-free for at least 2 years because we wanted to look at them having survived their treatment and what their quality of life was related to that primary treatment. We administered a number of these questionnaires. It was by mail or telephone. It took patients 45 minutes to 60 minutes to complete. Here are all the instruments, and I won't go over them all, but these are all the instruments that we used. So this was pretty thorough. These are all validated instruments, some bladder specific. We used EPIC just to get some of the more bowel stuff. That's drawn from the prostate world because maybe radiation is worse on bowel than cystectomy. And then we had some impact and perception of cancer scales too. So 226 patients were eligible. Our response rate was 77%, which was, we thought, very good. 63% had had a cystectomy, 37% had had trimodality therapy. And the median time from diagnosis to filling out the questionnaires was 6 years for cystectomy, 9 years for trimodality therapy. So this was long-term survivors, is the point. As best as we could tell, again, we didn't have their baseline questionnaires, which is a big limitation of this study, but we tried to look at how similar were these patients. Their age was similar, their gender was similar, and their comorbidity scores at baseline were not statistically different. And race wasn't different, tobacco use, GFR, tumor stage, performance status, or BMI. Those were all similar between these two cohorts. I'm going to go through a few slides that look like this. Long story short, anything in blue is a point effect estimate in favor of trimodality therapy over cystectomy, okay? And you see the significant p-values on the right. So as far as the EQ5D, which is a general health-related quality of life questionnaire, 5 questions, and a longer questionnaire from EORTC that looks at global health, physical functioning, role functioning, emotional, cognitive, etc. There were benefits to trimodality therapy over cystectomy. Now looking at domain-specific urinary, bowel domains, there were benefits, again, to trimodality over cystectomy. Some more modest ones in the bowel area. But still statistically significant. If we look at sexual, this is big. Look at these effect estimates. You're looking at effect estimates of 20 to 30 points. Way, way better for trimodality therapy than for cystectomy. Remember, those patients were about the same age. They had the same kind of comorbidities. Way, way better. And then if you look at something like cancer treatment perception, cancer control, those weren't different, but informed decision, patient sense of them having made an informed decision, significantly better for those who had trimodality therapy, and some other things as well. Long story short, what's different, what's clinically significant versus statistically significant in this kind of work, sometimes hard to define, but in general, points that are between 6 and 11 points on most of these scales are thought to be significant, and what we see is that the bowel stuff, there is the range in advantages for TMT of 3 to 7 points. Maybe that isn't significant, and actually was a surprise to us. We thought radiation would have had worse bowel. But sexual was really definitely significant, and this impact and perception of cancer was better, including informed decision making. So this conclusion slide basically summarizes those points that I just made. So I've gotten a radiation oncologist and a medical oncologist, Walt Stadler, to say the following, or I've heard them say that the best bladder you'll ever have is the one you were born with. I'm still looking for a urologist to say this statement. But we do believe that acceptance of chemoradiation in the with modern bladder-sparing therapy should not be limited by high rates of late pelvic toxicity. And I just want to show you, I'm in the last just 3 or 4 slides. There is a great experience, a very honest experience from Memorial Sloan Kettering, looking at over 1,000 radical cystectomies. This is primary radical cystectomy, and reporting on complications using a validated Clavian scale. Long story short, 2/3 of patients had more than one complication. 13% were grade 3 to 5. A quarter of patients required readmission after a cystectomy, and there was a 2% 90-day mortality rate. Okay? This is a high-volume, specialized center doing cystectomies. So remember, there are 27% in our cohort, 15% in the modern era, but 27% overall required a salvage cystectomy. So we did a study using the same Clavian scale in those patients. Sloan Kettering results are on the right, ours are on the left. Just look at grade 3 to 5. So grade 3, we were 14%, they were 11%, and this is those getting salvage cystectomy, right? So ours is salvage cystectomy, theirs is a primary cystectomy, never saw radiation. Grade 4, 2%, they had 0, and grade 5, it was the same at 2%. So maybe a little more, but basically acceptable, basically comparable. So we do feel that in those patients who have to have a salvage cystectomy after radiation to their bladder, that it is doable with acceptable toxicity profiles. This is an ongoing RTOG study. Please consider enrolling in it if you have it open on recurrent T1 BCG refractory disease, trying single-arm chemoradiation. There's a lot of work going on in stratifying patients based on predictive biomarkers. I won't get into that. And then Dr. Davis actually presented some of the combinations of radiation and immunotherapy. This is very relevant now in bladder cancer, where radiation can liberate antigens, lead to maturation of dendritic cells, and lead to effective T-cell priming. So there's a lot of work on that. This is one of the papers that Dr. Davis pointed out earlier, suggesting that the top one is showing that there is an abscopal response in over a quarter of patients getting radiation and immunotherapy. So there are a lot of effective potential relevant therapeutics in this domain that are listed there. In the world of bladder cancer, this is being looked at trials that are being developed. And then the question is, well, what dose of radiation do we need to give, and what is the timing in the sequencing when you're giving it with immunotherapy? These are things that are being worked on. So some things to look for the future. A lot of studies being developed in this. So last slide. In this whirlwind, I hopefully have shown that many muscle-invasive bladder cancers are not getting curative treatment in the United States. There is an undertreated and underserved population, especially amongst the elderly. Trimodality therapy achieves a complete response and preserves the native bladder in over 75% of patients, better results in the modern era, while offering long-term survival outcomes that are comparable to contemporary radical cystectomy series in well-selected patients. Long-term health-related quality of life is good, and we do believe that these results support such therapy as an acceptable alternative to cystectomy for selected patients. It's supported by a number of guidelines, And I think as we see the new guidelines coming out this next year, there will be further place for chemoradiation in this disease. We need to continue to validate predictive biomarkers and personalized treatment, and we really need to continue multidisciplinary engagement. Frankly speaking, I think muscle-invasive bladder cancer patients should see all three disciplines. They all have a potential role. We heard it nicely from John. Sometimes after cystectomy, it could be used. We know neoadjuvant chemotherapy is common in this disease, so they should see medical oncologists, and they should see us in radiation oncology. And with that, I thank this large multidisciplinary group that helped with all these results. Thanks for your attention.